Hello everyone and welcome to my channel and another video about clinical pharmacy practice. In today's video I'm planning to talk a little bit about a med review, how to write a med review if you're requested to do so as a clinical pharmacist. This is just one simple example. You can, as I mentioned before in previous videos, you can write med reviews in so many different ways. A SOAP note or a farm note or whatever you want to call it. Whatever you use or whatever you feel comfortable with, you can use that in practice as long as it has all the necessary information and it answers the requester's questions. So today we'll have a case. Actually, it's a case that we used in previous videos, and we're going to do a med review on the case and see if the patient needs any changes or interventions in their therapeutic plan to optimize the therapeutic plan, which is our goal usually. So yeah, hopefully at the end of the video you'll be able to identify drug therapy problems and create a medication review that is proper and professional as a clinical pharmacist. For those of you who are new on the channel, this channel is all about clinical pharmacy practice. I teach you how to become clinical pharmacists, how to advance your careers. If this is something that interests you, make sure to subscribe to the channel and also activate the bell so that you get notified of my future videos. Also, those preparing for the PEBC exams or the pharmacist licensing exams in Canada, I do have a chapter on my channel about PEBC exams and specifically the osces and how to train you on the osce if this is something that helps you. And we also have our course, PEBC training course. So yeah, make sure to check the descriptions in order to get the discount code for the course if you're looking for one. All right, let's get started on today's case. So this is a 55-year-old female patient who was brought to the ER with symptoms of chest pain. Her past medical history includes hypertension, atrial fibrillation, and osteoarthritis. Home medications include amlodipine 5 milligrams daily, rivaroxaban 20 milligrams daily, and acetaminophen 500 milligrams TID. And for those of you who don't know what acetaminophen is, that's similar to paracetamol in different parts of the world. So here in North America, we call it acetaminophen. The patient has no known drug allergies. Laboratory studies showed elevated troponins, and her ECG showed STEMI. So that's ST segment elevation myocardial infarction. Her creatinine clearance was almost normal, 95 mils per minute, and other labs were all within normal range. The patient was immediately taken for an angio, and she underwent a PCI with 2 drug-eluting stents implantation. PCI was completely fine. The patient was stable after that. She is now ready for discharge, and the physician has filled a discharge prescription with her home medications. So he continued the home medications, which we mentioned above, and added aspirin 81 milligrams daily and clopidogrel 75 milligrams daily. You are the clinical pharmacist on duty, and the physician would like you to review the discharge prescription before the patient leaves. Please complete a medication review with your suggestions, if you have any suggestions. The patient's vital signs today were 148/85, heart rate is 130, respiratory rate is 28, and temperature was normal. All right. Now, the first thing you need to look at when you're reviewing such cases, of course, you'll have more laboratory studies, but they mentioned here that the lab studies were all normal, besides the elevated troponins. They mentioned the creatinine clearance, which was kind of normal, and her ECG was abnormal before the stent, 2-stent implantation. So we have a really good idea about the patient here. We have their vital signs also, so and her history. So what you need to look at immediately is her past medical history, her current problem, which is the STEMI and the PCI that she went for. So this is the current complaint, and this is the past medical history. So those two together. So she does have previous conditions as well as the new condition, which is the STEMI. And then you start to think about a plan. If something is needed to be added to her plan, to her therapeutic plan, to optimize it, or if something needs to be removed or something needs to be changed. It could be anything, right? But yeah, this is how you should start your thought process. So let's move on to the next slide here. So we know that this is a 55-year-old female patient. She's admitted with a STEMI, and she's status post-PCI plus 2 drug-eluting stents. This is basically the med review right now, the medication review that you are going to write in the chart or document it somewhere in the hospital documentation system. And then you have to mention the past medical history, which is hypertension, atrial fibrillation, osteoarthritis. And for those of you who haven't seen my previous video about how to write a medication review or how to write a SOAP note as a pharmacist, please check on the channel. You'll find another video that teaches you step-by-step wise how to write a SOAP note. Laboratory studies, you can mention that important lab results obtained during admission. I didn't mention anything here because you should be mentioning whatever pertinent important lab studies that were done during admission and the results of those lab studies. If any of them was abnormal, you probably should mention that first, so that the reader would immediately notice the abnormal lab results first. And then home medications, you have to mention the home medications plus the doses. Don't forget to mention the doses because these are very important. Most MRPs or physicians who work at the hospital usually don't forget to mention the home medications in their consultations, but almost always, like 80% of them, forget to mention the doses. And doses are very important, especially if this patient will be admitted in the future. We need to know what was she on, what dose was she on, and that too. If you don't have a tracking system where you work or where you live that tracks every medication the patient dispensed in the community or from the hospital, so it helps a lot when you keep those doses on your med review. Now, current medications on admission, you have to mention both. You have to mention home medications, so that's the best possible medication history, and also the current medications in hospital, which would be the same, plus aspirin and plus clopidogrel. Allergies, no known drug allergies, we have to mention that too because we're starting new medications on this patient, which is aspirin and clopidogrel. So we need to know that if the patient has a history of aspirin allergy, for example, or something like that. And then vital signs obtained from the hospital system. Now, later, after that, you should mention your assessment. And under assessment, you have to mention the drug therapy problems from your opinion. And here are the problems that I've noticed. First of all, the triple anticoagulation. So this patient is on rivaroxaban, 20 milligrams, and she got started on aspirin plus clopidogrel. I know that aspirin and clopidogrel are antiplatelets, but we call them anticoagulants as well. And especially when they're combined with oral anticoagulation such as rivaroxaban or warfarin or apixaban, whatever it is, that qualifies this combo to be named triple anticoagulation. This is in North America in general. So why am I worried about that? There's another video that we talked about atrial fibrillation plus acute coronary syndrome and how to manage anticoagulation. Make sure to check out that video too because I talk more about the anticoagulation regimen in that video. But this is just like a completion of the video because in the previous video I did not really mention how to manage the other drug therapy problems because we were only focusing on the AFib plus ACS guidelines. But today we're focusing about everything because we are med reviewing the patient. So what's wrong with the triple anticoagulation? So this patient went for PCI and 2 drug-eluting stents, so she needs dual antiplatelets for sure. She was started on that, on dual antiplatelets. The patient also has a history of atrial fibrillation, for which she uses Rivaroxaban 20. And now, due to the higher risk of bleeding when combining 3 anticoagulants, the American Heart Association and the American College of Cardiology has specific recommendations on dosing and duration of these medications. And then I mentioned see below under recommendations. So this is my concern here. This is the drug therapy problem. We are combining 3 anticoagulants, which might need some adjustments. And I'm going to mention that under my recommendations. So right now, we don't have to mention recommendations because you're just mentioning all the drug therapy problems one after the other. And this is only the assessment part. It's not the recommendation part. The second problem here is the ACS optimal medical therapy. This patient had an acute coronary syndrome and she went for a PCI. So she requires optimal medication therapy after the PCI. This should include an ACE inhibitor or an ARB and a high intensity statin. We can continue amlodipine while monitoring the patient. And why am I saying that? Because the patient had an angina as well, which led probably to the myocardial infarction. So you can continue the amlodipine. It's not contraindicated while monitoring the blood pressure and reassessing the dose in the future. Because why am I saying that again? Because we are starting another blood pressure medication controller here, which is the ACE or the ARB. So you're adding a new antihypertensive and hormonal modulator, and the patient is already on an antihypertensive, so you might want to monitor the blood pressure closely. A beta blocker might also be needed to control her atrial fibrillation and also to relieve any residual anginal symptoms. Beta blockers actually should have started immediately as soon as the patient presented, but in this case, we don't see that. We didn't see that happen. So yeah, you can start a beta blocker right away. Although because she went for a PCI, she might not really need beta blockers on the long term. However, she has another compelling indication for a beta blocker or rate control, which is the atrial fibrillation. So in this particular case, you can continue the beta blocker for the long term to control her rate. And why am I worried about the rate? Because look at her heart rate up here. It's 130 beats per minute, and that's not the goal in a patient with atrial fibrillation or even a patient who just had a heart attack. So now we have 2 drug therapy problems, and as you can see, the first one is very risky, risk of bleeding, so I kept that number 1, and then number 2 right away is the second most important drug therapy problem. Let's see if we have any others. We don't have any others. In my opinion, I don't have any other important drug therapy problems to bring up here. So I am going to, I'm straightly going to recommendations here. And again, I'm going to mention number 1 in regards to triple anticoagulation. And here are my recommendations now. Now, this will continue different drugs, different recommendations. I'll have to mention guidelines that I am referring to, like references. I have to mention everything so that the reader would understand what I'm talking about. If they want to go back and check, they could. Most of the time, they don't check. They will take our recommendations as is. But when you mention them in a proper way, it makes them more confident when they're taking your recommendation. So I recommend to switch to the following anticoagulation regimen as per the ACC/AHA atrial fibrillation guidelines of 2021. And I made sure to mention the year because the guidelines change over time. So if you look at the guidelines from 2018, I think, and previous, you will find that some of the doses and the duration of anticoagulations are actually different. That changed later on in 2020 maybe. So yeah, you have to make sure which guidelines you are referring to. If you're referring to the 2018 guidelines, then my recommendation here would be completely different and it would be wrong because that has changed already. So what do I want to do? Continue aspirin plus clopidogrel plus rivaroxaban 2.5 milligrams BID only, not 20 milligrams once daily. And all of these from 1 day to 1 month post PCI. So only for up to 1 month post the PCI. After the first month, discontinue aspirin and increase rivaroxaban to 15 milligrams once daily, or 10 milligrams once daily if the creatinine clearance drops between 30 to 50. And also continue clopidogrel 75 milligrams daily. Now, this is dual anticoagulation for up to 12-month post-PCI. So I gave them a dose, I gave them which regimen to follow, and I gave them frequency, and I gave them duration as well. I gave them all 4. And this is very important, especially if your hospital is going through accreditation or something like that. They need to know, they will check, and they need to see you mentioning everything, not just a medication name or half of a recommendation, like medication name plus dose, and you forget about the duration or the frequency. That's unacceptable. Finally, after 12 months post-PCI, discontinue clopidogrel and increase rivaroxaban to 20 milligrams once daily. Dose should be adjusted for kidney function. At this point, I cannot give recommendations for kidney function because I don't know after a year where is this patient going to be sitting in terms of kidney function. But at least I told them that those should be adjusted per kidney function. So 20 milligrams daily is the usual dose. But again, if the kidney function is poor, then a dose adjustment might be needed. Number 2, ACS, optimal medical therapy. So the optimal medical therapy for acute coronary syndrome, I recommend the following. Start an ACE inhibitor and titrate to optimal dose. If there is a contraindication to ACE inhibitor, you may use an ARB instead. And do you guys know what are the contraindications to ACE inhibitors? Let me know in the comments. This is very important. You should know that by heart. So let me know if you're aware of some of the contraindications of the ACE inhibitor. They are very few, not too many. Number 2, start a beta blocker and titrate to achieve rate control in AFib. So that's another major thing that I'm looking for here. And number 3, reduce amlodipine dose to avoid hypotension. If blood pressure, atrial fibrillation, and angina symptoms are controlled with the new medication regimen, which is beta blocker and ACE inhibitor or ARB, then amlodipine may be discontinued in the future. So I don't see a reason why the patient should be on amlodipine in addition to everything else, unless she is hypertensive despite everything else. And then the last recommendation here is to start atorvastatin 40 to 80 milligrams daily or other high-intensity statins. Again, for high-intensity statins, we have very few recommendations. I hope you guys are aware of those. You should review the different statins, which ones are high intensity, which ones can only be medium intensity or low intensity. And you should learn the doses by heart, especially if you only have a few of them on your formulary at the hospital where you work. Or if you don't work in a hospital, even if you're working in a pharmacy, you'll only have a few statins. You won't have all of them. So for the ones you have, you should be aware of which one can be recommended as a high intensity statin or a medium or a low intensity statin, because you might get that question from a physician who has a patient and they really need a high intensity statin. You cannot go and say, oh, you can use simvastatin 40 milligrams. You can't do that. That's not a high intensity statin. So you need to be aware of the dosing of statins as a clinical pharmacist. So I would suggest you review those. You can find them, just Google different intensities of statins or whatever, and you will find them on Google. All right, and these are my recommendations. Do we end up here and say thank you and sign the recommendation or the med review? No. Don't forget the most important thing that I keep reminding you, the monitoring plan, because you are suggesting newer medications now. and somebody has to monitor that patient for lots of things. So monitoring plan, you need to monitor for blood pressure, heart rate, regularly. So even if the patient gets discharged, she needs to monitor herself at home. Baseline and periodic serum creatinine, blood urea nitrogen, and potassium levels. And do you know why we're doing these? Because we are starting ACE inhibitor or ARB, and you have to make sure that you have a baseline data on all of these. And of course, if the potassium is higher than 5, and if the kidney function is already abnormal, you have to have that baseline data, because as soon as you start an ACE inhibitor, there might be a decline in kidney function. So you need to do all these calculations as you go, as you're monitoring the patient. And of course, if the potassium is more than 5, you should not be starting an ACE inhibitor until the potassium normalizes, because it will increase the potassium as well, right? You should also monitor for bleeding risk, because the patient will be on triple and dual anticoagulation for a year. So you have to monitor for bleeding, and CBCs also, which will help you to look at the hemoglobin. If there's a major drop in the hemoglobin, then you know that there might be a bleeding happening. And finally, you should monitor for angioedema, of course, a side effect or adverse reaction from ACE or ARB if the patient has never had these medications before, and how to manage these adverse effects if she experienced any of them. So usually we would, after the patient gets started on that medication, we would go and talk to the patient and counsel them on such adverse effects and what to expect and how to manage them. All right. The physician accepted your recommendations. Congratulations. And the patient gets discharged successfully. Actually, before I get further into the case, so this patient was actually started on these medications right before the PCI, because the PCI happened at a different hospital. So the patient had to be transferred to another hospital, and that hospital started the ACE inhibitor, atorvastatin, beta blocker, metoprolol, and everything was good. And they even reduced her amlodipine, and started the aspirin and clopidogrel, and even adjusted the rivaroxaban to 2.5 BID. So everything happened in that other hospital in their cardiac cath. However, after the PCI, the patient got sent back to the hospital where I was covering, and on transfer, they have to send a medication list, and that medication list was missing. So they didn't send the new medication list. They sent the old medication list for the patient prior to admission, which was had nothing in it, and they only added aspirin and clopidogrel on that list, and that's how these medications got missed. So initially they were all started, but that's how it got missed, and that's why it's very important to do medication reviews or medication reconciliation every time the patient comes to the hospital or gets admitted to the hospital, even if she just got transferred and to another hospital and then transferred back, because misses happen with transfers. So you have to be on top of it. You have to review the patients immediately as soon as they come to the hospital. I just wanted to mention that because, it doesn't make sense that the patient just had a PCI and she's not on any of the optimal therapy. It doesn't make any sense, right? Because the PCI was done by a cardiologist, so they know very well these medications and how important they are. Okay, so this is what happened. 2 months later, now the patient got discharged and she's on those medications, and 2 months later the patient develops increased shortness of breath with exertion, and she comes back to the ER. Her chest x-ray showed bilateral pleural effusions, and her labs showed elevated BNP of 1250 picograms per mil. An echo was ordered, which revealed a left ventricular ejection fraction of 25%. Now, the patient received a new diagnosis of heart failure with reduced ejection fraction, New York Heart Association Class 2. You are rounding with the emergency doctors, and they ask you if the patient's therapy could be optimized further. What is the patient on? The patient is on ramipril 10 milligrams daily, metoprolol succinate 100 milligrams long-acting pill daily, atorvastatin 80 milligrams daily, rivaroxaban 15 milligrams daily, and clopidogrel 75 milligrams daily. She's also on furosemide 40 milligrams twice a day and acetaminophen 500 milligrams TID. You can see that the regimen is completely different from 2 months ago, before her PCI. Okay, what would be your recommendation at this point? All other labs were within normal range, especially her eGFR was 70 mils per minute, so it was good, and her potassium was 4 milliequivalent per liter. Would you have more recommendations at this point, or would you recommend to continue the current regimen? Bear in mind that the patient is on 10 milligrams of ramipril now, once daily, and she had an ACS 2 months ago, and she already has hypertension. She's also on 100 milligrams of metoprolol, which is a decent dose. We don't have her vitals at this point. There must have been vitals, but I don't have it here. But in general, now with the new diagnosis of heart failure, what do you think? Now let me give you a few tips. There is a new medication that got introduced to the market, I want to say a few years ago, I can't remember exactly when, that has been seen to be superior to ACE inhibitor or ARB in patients with heart failure, specifically, especially if they were already on a good dose of ACE inhibitor or an optimal dose of ACE inhibitor. Ramipril 10 milligram is optimal for post myocardial infarction patients, and even for heart failure, 10 milligram once daily should be enough. It's an optimal dose. Remember what medication I'm talking about? It's the sacubitril valsartan, the angiotensin receptor neprilysin inhibitor. That's what I'm talking about. So, according to the American Heart Association and the American College of Cardiology, if the patient has heart failure with reduced ejection fraction, New York Heart Association classification 2 to 3, which is the case here, this is class 2, it's recommended to use an angiotensin receptor neprilysin inhibitor to reduce the mortality and morbidity. Studies have shown that the angiotensin receptor neprilysin inhibitor is superior to ACE inhibitors in those patients. However, that medication is not available in all countries, and even if it's available, it might require certain special authorization or applications to apply for it, because it's kind of still expensive to purchase. So if you can't switch from ramipril to sacubitril valsartan, you can continue ramipril. But I just wanted to bring that up in this presentation, because some of my followers are taking the PEBC qualifying exams, and that might be a question. So make sure to review the guidelines for heart failure and what are the current recommendations for those. Now, what else? What other things do we need? Beta blockers for heart failure. Okay, the patient is already on metoprolol succinate long-acting 100 milligrams daily. Do you think that this is a good beta blocker, or should we switch to another one? Given that, let's say that her heart rate and her blood pressure is well controlled, both of them are well controlled. Heart rate is within normal range. let's say it's 60 and blood pressure is less than 140 over 90. So what do you think? Does metoprolol help those patients, or should we switch it to another beta blocker? There's one more thing when you look at the heart failure guidelines today, which is fascinating. So there are newer drugs that are included on the heart failure recommendations or guidelines nowadays, and one of those drugs is actually an MRA. So mineralocorticoid receptor antagonists like spironolactone, for example. This is one of the drugs that is recommended for heart failure reduced ejection fraction with a New York Heart Association between 2 and 4 to reduce morbidity and mortality. So that's something maybe that wasn't a thing a few years ago. This is kind of new. So if the GFR is more than 30, which is the case here, the potassium is less than 5, you should start or recommend to start a spironolactone or eplerenone in this patient. Of course, you have to carefully monitor the potassium and renal function, and the dose of the MRA. You should start with a lower dose and titrate slowly. But yeah, that's one of the medications we recommend in heart failure and reduced ejection fraction patients, especially post ACS. So she had a heart attack recently with a reduced ejection fraction, so an MRA is very important in this case. The last medication I would recommend on this patient, which is also a newer medication and also on the heart failure guidelines, would be the SGLT2 inhibitors, or specifically the dapagliflozin, that the studies showed how important it is to reduce hospitalization in heart failure patients and reduce cardiovascular mortality. However, if you don't have dapagliflozin, you can use empagliflozin. The whole class basically will have similar benefits, but the studies didn't show, I think, good results except with empagliflozin and dapagliflozin. I cannot remember the studies on canagliflozin, but it might also be used. So basically, yeah. So ACE inhibitors or ARBs under heart failure now, heart failure recommendations with reduced ejection fraction, ACE inhibitor or ARB, beta blockers, and there are only 3 that have been studied. One of them is metoprolol succinate. Here you go, I gave you the answer. You should know which 3 are acceptable to be used for heart failure with reduced ejection fraction. Metoprolol is one of them. Maybe let me know in the comments which other 2 can be used in heart failure patients. So ACE inhibitor or ARB or ARNI, which is the angiotensin receptor neprilysin inhibitor. That's the first recommendation. Second recommendation, beta blocker. Third recommendation would be MRA or spironolactone or eplerenone. And fourth recommendation would be an SGLT2 inhibitor, such as dapagliflozin or empagliflozin. Those are the 4 guideline directed medication therapy that are very important as soon as the patient gets diagnosed of heart failure with reduced ejection fraction. All right, that's it for today. Let me know in the comments if you have any questions, and don't forget to check out Pharma ePass. They have a massive course for PABC preparation, for the preparation of PABC exams, including evaluating exam, qualifying exams, and soon they will have OSCE training as well. If you are looking for something like that, make sure to use the code in my description under the video. It will give you a discount of $200, which is worth it. You can save $200 basically on any of their courses. So yeah, and let me know if you have any questions also in the comments. Thank you for watching today's video, and another video coming up soon, so stay tuned. Have a great day.